issues, very well attended. I think some ideas in the future could be something on an ophthalmologic topic, and we've been kicking that one around. We have coming up a visiting professor, Dr. Attar, the chief of cardiology at Western Galilee Hospital. He's going to be coming here for about 2 weeks' time, splitting his time between St. Luke's and Lehigh Valley Hospital. I know that Darren Traub's going to be involved with him out at St. Luke's, and that's going to be a really nice opportunity. We'll have another brunch with him here on updates in some cardiology topics with him. I know that Jean has been working tirelessly along with Judy to help arrange for social schedule for him. I think his academic schedule is fairly set up. Jeff Gevertz is helping to coordinate that. If you want to be involved with his academic schedule, certainly you can contact Jeff Gevertz. If you want to host him for dinner, please be in touch with Jean. And Jean, is there anything you want to add about the...
Just the one thing, where's Barry? That this is, I think this is the best Maimonides Society in the country, but I hope everybody's aware that it's also the first in the whole country. It's over 25 years. And Dr. Attar is arriving on the 28th of this month. He will be with his wife, and he leaves on the 14th. One of the most enjoyable experiences is to have a doctor from Israel at your home, to meet your kids, to go over the politics of Israel, what's happening, either host them at your home or go out to dinner, whatever you want to do. So we do have openings, and if you're interested in doing that, perhaps have a couple of class, just would you contact me after the meeting, and I'd be happy to arrange a date. There's a lot of open dates. Okay.
No.
No.
As far as I know. And he's in his early 50s, I think. Is that it? Yeah. And he's the chief of cardiology at Maimonides Hospital. And is there anything else that we need to know about?
He's traveling with his wife, and she'll have time during the days
Yeah.
if there's anybody who wants.
Right.
Yeah.
Yeah.
A couple more comments and then we'll get started. A nice story, I was biking last week or the other week with a group of guys that many of them are in this room. It's nice to see them face to face. Most of the time when I'm biking, I'm just looking at Harvey's backside because I'm trying to chase him and keep up with him, and Bill Markson, but so it's nice to be face to face with him here. But one of the guys biking with us the other day said that a great experience he had was about 20 years ago with a visiting professor from Israel, radiologist, and he's still in touch with that gentleman. And in fact, he and his wife and the radiologist and his wife in Israel will often get together when either one is visiting the other one's country, and I think that's really, really nice.
The biking group is a Maimonides bike group?
And I'll tell you too as well, I mean, it's sort of turned into a Maimonides bike group, but there's a group of guys who tend to ride on Sundays, and Paul is here, and Harvey is here, Bill Markson goes, Mike has ridden with us, a lot of guys, Judy rides with us as well.
I'm a token. Twitter, at Hampton Road Rides.
If you're really up on your tech, you can Twitter at Hampton Road Rides, and Bill will send out a notice of who's going to ride or what time we're going to meet. Usually it's 8 a.m. on Sundays at Bill Markson's house on Hampton Road. And then the last housekeeping issue, and then I'm going to introduce these guys and we're going to get started. I want to thank not only everyone in Maimonides, but other community members as well coming. And I also want to introduce Israel Ziegelboim. Israel is a new gynecological oncologist. He's working in St. Luke's. He's literally been in town for a month or two, and he's just taken off and obviously wants to be involved with the Jewish community, and I think that's outstanding. So let's talk about what we're going to deal with today. We're going to talk about men's health issues. We have a panel up here. I recruited the best guys that I could find to talk about some men's health. Mike Zager, he's an internist here in town. He did his undergraduate work at Penn, went to med school at Ross. He trained here in the Lehigh Valley. He's an internist here with Lehigh Valley Hospital. And he's going to sort of give us a broad overview on men's health, metabolic syndrome, and the like. Mike will tell us more about that. And David Bubb is here. David did his undergraduate at Penn as well, med school at NYU. Where'd you do your general surgery?
St. Luke's Roosevelt.
St. Luke's Roosevelt, and then he did a fellowship in colorectal surgery in Baltimore. So we're going to let David start first today, basically just telling us a little bit about colon cancer screening, and then Mike's going to go and he'll give us sort of more of an overview, and then I'm going to talk about something that I find that I see a lot in clinical practice, and that's low testosterone and supplementation of testosterone. So without further ado, I'll introduce David and he can get started.
I want to thank Frank for inviting me to come and talk about colorectal issues. I consider myself a manly man, so I thank you for inviting me. And I also thank Frank for volunteering for demonstration purposes later in the talk. As we're watching all the debates, you know, it's interesting how everyone refers back to Ronald Reagan. And it's easy to forget that Ronald Reagan was diagnosed with colon cancer. Some recent other people, Robin Gibb, and I actually think his brother also died of colon cancer. It was reported that he died from surgery related to a small bowel obstruction. So it's kind of, you know, terrible that his brother died of colon cancer, and then he died of colon cancer also. And then everyone can remember Darryl Strawberry. So the point being that, you know, colon cancer doesn't discriminate based on your political views or whatever music choices you like. It's very common. If I can have the next slide. Among men, most common is prostate cancer, Frank will tell you, and followed by lung cancer and colon cancer. Among cancer deaths, lung cancer causes more deaths than prostate cancer, and finally colon cancer. For men and women, colon cancer is the second most common cause of cancer deaths. It affects about 6% of the population, and every year there's over 150,000 cases of colon cancer diagnosed. I don't have to tell everyone here because you're all doctors, but colon cancer is the one thing that should be completely preventable with appropriate screening, and that's what we want to talk about. Basically, I think of cancer screening in tests as one of two tests. They're either cancer detection tests, where we're simply going to detect that you either have polyps or you have cancer, or we can do cancer prevention tests, which are actually going to prevent you from developing colon cancer. So, while the tests listed at the top, the fecal occult blood testing, the immunohistochemical testing, and virtual colonoscopy can help detect colon cancer, colonoscopy can help prevent colon cancer. So it's the preferred method of screening. I would basically recommend getting a colonoscopy every 10 years. Fecal occult blood testing and immunohistochemical testing have been shown to decrease the incidence of colon cancer. But again, once you have a positive test, you then have to have your colonoscopy. Next slide. Does colonoscopy work? And the answer is yes. There's been large trials which have shown decreasing the incidence of colon cancer with colonoscopy. This is a slide showing the incidence of cancers over the last 15 years, and you can see since the 80s there's been a steady decrease in the incidence of colon cancer. I think all of us believe this to be due to the introduction of colonoscopy in the 80s.
David, can I make one comment on that slide?
Sure.
So in 1989, PSA testing basically came out, 88, 89, and that explains this spike right there.
I wondered what that was. Okay. And again, the goal of colonoscopy, I don't want to be too redundant here, basically to identify polyps before they can grow into cancer. Polyps begin as adenomas, and through a steady progression of the genetic mutations grow into cancer. This progression is well defined, and we believe it takes about 10 years, and so that has led to the rationale behind our colonoscopy screening. Next slide. This is the classic adenoma-carcinoma sequence. Starts off with a defect in the APC gene, followed by a series of mutations that occur in the cells, and eventually goes on to cancer. This is important because this is what we base all our screening on, this carcinoma sequence. Next slide. So just to review quickly what the recommendations are, basically we recommend you get a colonoscopy beginning at age 50. If it's negative, every 10 years after that. Other options include fecal occult blood testing, FIT testing every year, sigmoidoscopy every 5 years, virtual colonoscopy every 5 years. I think most of us recommend colonoscopy every 10 years. Incidence is slightly higher in African American patients, so we can start screening at age 45. And it's been shown with obesity and smoking, also higher incidence of colon cancer, so a consideration to start screening people at age 45. Next slide. If you have a family history of colon cancer, we want you to get screened earlier. So if you have a first-degree relative who was diagnosed with colon cancer, if they were diagnosed after the age of 60, you basically fall into the average screening risk, and we would recommend getting screening at age 50. If you have a first-degree relative diagnosed before age 60 or 2 first-degree relatives with colorectal cancer, we recommend screening earlier, probably at age 40 or 10 years before the age of diagnosis. So if you have a family member diagnosed at age 45, we're going to recommend you get screened at age 35 and start working you up for a genetic cancer syndrome. Next slide. If you have polyps, what should you do? When should you have your next colonoscopy? Low-risk polyps, 1 or 2 adenomas, less than 1 centimeter in size, favorable histology, we would say repeat the colonoscopy in 5 years. High-risk polyps, large polyps, more than 3 polyps, repeat the colonoscopy in 3 years. So that's all you need to know about colonoscopies.
Your first colonoscopy starts earlier with family history. Does your interval change, or you still at every 10 years? So if you're starting at 45,
Every 5 years.
so then it's every 5 years.
Yes. So this is the part about colonoscopy screening that I find very interesting. It's the new controversies and data that's coming up. A couple things. When we do a screening colonoscopy, we're trying to find polyps on an index screening colonoscopy about 20% of the time. 15% we'll find in women, 25% we'll find in men. We'll find polyps at their index screening colonoscopy. So the question is, how is it that we find less polyps in women? However, the incidence of colon cancer is still the same. It doesn't make sense. You would expect that women would have a lower incidence of colon cancer than men. Another issue is that we see patients still who get colon cancers after having a colonoscopy 3 years ago. How does that happen? Is that a missed polyp 3 years ago, or is there a faster growth of that cancer that caused their colon cancer? So these are things that I find interesting. And next slide. And the reason for that is what we believe now is the serrated adenoma. This is the hot topic in colorectal and gastroenterology. This is a picture of a serrated adenoma. If you can go to the next slide. Serrated adenoma is a polyp that we know follows a different genetic pathway than the other adenoma carcinoma sequence that we showed before. This is based around a mutation in the BRAF gene, and it develops through an alternate pathway. No one knows how fast this pathway occurs. It's probably similar to the pathway we see in patients who have hereditary cancer syndromes, and we know that those patients can develop cancers more quickly. So it's an interesting new finding, if you can go to the next slide. So serrated adenomas are more common in women. They're more common in the right side of the colon. And in general, they're very hard to see. I mean, just looking at that slide, when you're doing your colonoscopy, they're very similar to the mucosa of the colon. They're flat. They have indistinct edges. They don't protrude into the lumen. And we believe that these could be a disproportionate percentage of the missed polyps that go on to develop into cancer.
Do they present on virtual colonoscopy any better?
No. Virtual colonoscopy is very good for larger polyps, but a flat polyp you will not see like that on a virtual colonoscopy.